Hi, everyone. Thank you so much for joining us. My name is Amer Zeidan, and I'm Associate Professor of Medicine at Yale University. And it's a true pleasure to be here with you today, where we will be discussing the main updates from the American Society of Clinical Oncology meeting, as well as the European Hematology Association meeting, both of them held in early June. And we'll be discussing updates on the myelodysplastic syndromes, also named as myelodysplastic neoplasms. This was a very rich meeting, especially on the lower risk MDS, with I think 2 important studies. So we'll be discussing not only the lower risk MDS, but we'll also discuss high risk MDS, as well as updates in classification, prognosis, and where the field is heading. It's a true pleasure to be joined by 2 of my friends and colleagues who are both top experts in MDS, Dr. Borate, who's currently at the University of Ohio. She's an associate professor there, and she focuses on MDS, AML, as well as CHIP, and has been a leader in the field with a lot of exciting studies. And also, we have Dr. Andrew Brunner, who's an assistant professor, but should be really an associate, hopefully very soon, at the Dana-Farber Cancer Center, and MGH, basically, where he also focuses on MDS and follows the field very closely and has a number of exciting trials, and some of the developments I think that he will share with us on the field are going to be very important. We are supposed to have Dr. Thomas Clouseau, who had a last-minute emergency, so he's not going to be able to join us, but the 3 of us will give you a very good update on everything that has been going on. So thank you so much, Uma and Andrew, for joining me.
Thanks for having us.
Sure.
Excited to be here.
Fantastic. So maybe we can start by a quick update, and maybe I can lay the kind of the ground for the updates on lower risk MDS and where we are, and then we can discuss for 15 minutes or so, and then Dr. Borate can discuss high risk MDS, which as she pointed out, there wasn't a lot of updates, but I think we can discuss some of the main directions of the field and where heading. But it seems like we probably should start with diagnosis, risk stratification, and classification updates with Dr. Brunner before we go into the therapeutics. So Andy, do you want to get us going? And what did you think were the most relevant updates in both meetings on that front?
Absolutely. Yeah, I think, it's an interesting time for MDS, all myeloid neoplasia in general. Every time we get an update in how we classify disease, we have a few things that we're trying to deal with. First, most of these classifications, they try to update our scientific understanding of the diseases. And so we have had tremendous advances. You think about how over the last 5 years, even we really have incorporated molecular diagnostics in completely new ways. We have much better understanding of subsets of disease. And so last year in 2022, there were 2 different classification systems that came out to update how we diagnose disease and how we classify it. And by and large, there's a lot of overlap between these. And I think that reflects how, as a field in general, we have grown together in how we address and classify what is a case of MDS and how should we use these new tools, molecular diagnostics, mutations, other factors to try to characterize this disease. But there are some differences between the 2. And so I think, on the clinician side, we see things maybe through a slightly, we all have our own lens of how we address diseases. And it is one of the big themes of the last year has been, how do we understand these 2 systems that have some minor differences? Where do those differences matter? Where are they important? And what direction can we take to try to merge them back into a single classification system? Because I think it is a little challenging when you're trying to talk to a patient and you have to not only talk to them about a disease and a new diagnosis that they have, but then talk about how different people classify it in slightly different ways, and whether or not that has implications for how you're going to help manage that person. And so, I think that one of the biggest things that we've seen at ASCO and at EHA this year our continued understanding of how we can better integrate molecular diagnostics and perhaps better synthesize these multiple classification systems so that in the future we can be back towards a cleaner, kind of more unified discussion. And so one of those aspects, for instance, is can we rely more heavily on molecular diagnostics? So for instance, the group led by Claudia Haferlack had an update of a genomic-based classification system that seeks to use strictly karyotype and genetic alterations to define subgroups of disease that have similar courses, whether it's using our blast cutoff, what used to be AML or MDS, or can we just merge everything together into a myeloid neoplasia? And in some of us, I think, understand where that can have great relevance. You know, for instance, probably the example that we use the most is TP53 mutated disease. It's not clear that once you're above 5% blast, that there's that much difference across the spectrum of MDS versus AML. So that is one direction where understanding better how genetic subgroups of disease really have a similar course regardless of blast count. That can be information that might help us coalesce some of these diagnoses in the future. I think also we saw some interesting work out of the Moffitt group trying to understand, you know, what are the strengths of each classification system, the ICC and the WHO. Where do they really make a lot of sense, and where are subgroups where maybe one of them, you know, we could add or modify that? And so they've also presented data where they presented a unified, more unified way of potentially merging these two classification systems. And I think this is a theme that we're going to start seeing more and more of as we proceed. I know that it often is a little challenging when you have a patient who falls into one of these gray zone diagnoses now to try to explain to them where the two classifications differ and whether that has any therapeutic implication. And so I do think over the last year, there's been a lot of effort to try to improve upon that. The other major change that we had in 2022, not just in diagnosis, so using the updated ICC and WHO to understand what disease you have, but then in prognosis, which historically in MDS has a couple implications. One, I mean, prognosis is important in talking to patients and trying to understand what to expect in the months and years ahead of their diagnosis. But for MDS in particular, we have divvied up patients kind of into people who we think have lower risk disease, meaning that you're going to live with your disease a long time and you're going to have symptomatic complications from that might be managed symptomatically, but that you're going to coexist with your disease, and patients who have higher risk disease, and patients who are more likely to have immediate complications in the coming months, and who have a high rate of transformation to leukemia. And that has largely divided how we manage them. And I think we're going to get into management strategies quite a bit as we keep going through this discussion today. But the incorporation of molecular data has really changed how we approach risk. And in some ways, I think that we are learning where that has its impact. So we had the IPSSM published in 2022. And over the last year, and including at ASCO and EHA, we've had ongoing updates in different cohorts trying to understand how the IPSSM plays out in real life, and in particular around treatment decisions. And some of the data that I think that has been emerging is where it has the most value and most impact. For instance, we've seen that when applied to transplanted cohorts, IPSSM really does seem to have prognostic value. So using the IPSSM to help you make a decision about transplant outcomes does seem to really have a lot of value. And I've actually started using that in my clinical practice as well, trying to take on a patient where I might have previously said, well, you have mostly lower risk features, your blood counts are okay, let's watch you. But now seeing that they have high risk molecular features, maybe I need to think differently about whether transplant, I can improve your outcomes with the transplant. The area where the IPSSM is still being evaluated, and where I think as emerging treatments are developed, we need to think about, is whether it has the same impact in non-transplant therapies, in particular in hypomethylating agents or azacitidine, But also, as we talk about newer therapies and new targets, does the IPSSM and do genetic subgroups have an impact on who benefits, and could it show evidence of disease modification in certain groups? And so we have seen that also data emerging over the last year, because we are using molecular data more and more, but I think we still have to recognize that the value of this new prognostication system is we're still learning how best to use it. And so I think we've made a huge stride in understanding different subgroups of MDS. I think that, we can be critical of how we try to advance the field, and it is a little tricky sometimes with two classification systems pathologically, for instance, for diagnosis. But, to be honest, they are both trying to incorporate mutations and other understanding of the disease in a more advanced and more tailored way for our patients. And so I think in many ways that's a great advancement. And hopefully, as the next year or two go on, what we can do is really learn how to better use these tools to treat our patients.
Yeah, thanks. That was a fantastic overview. And I think in the MDS field, for a long time, we did not really have great therapies. And I think we spent quite a bit of time, as they say, to keep slicing the pie and figuring out who's lower risk and high risk, and without having new treatments that can modify things. So we are running into the situation exactly as you outlined, is, we keep upstaging patients with new tools, but we are not clear how does that impact, therapies short of transplant. Uma, maybe, I don't know, like you follow the area of CHIP, clonal hematopoiesis quite closely. I wasn't sure if there were any relevant updates you had in mind, but also I wanted to get your thoughts about this issue of the ICC and the WHO in your institution. How are you guys handling it? Is your pathologist reporting both classifications, or I know each institution has developed their own kind of strategy of how to deal with this.
Thank you for that question, Amer. Yeah, in our institution, we are reporting both classifications, and I just wanted to echo Andrew and your comments on, I think it can cause a fair degree of confusion, both from the physician side, but also from the patient side. I think especially in the US, where a lot of these results get reported to the patient just at the same time they get reported to the physicians, I think it can be challenging to communicate and explain, if your patient has, let's say, 11% blasts, and the comment will clearly say, based on one classification, this is MDS/AML. Based on another classification, it could be a very, different or not the same diagnosis. When in reality, as Andrew, you mentioned, there's considerable overlap between what these classifications are trying to communicate, but from a clinical management perspective, it can make things challenging. I also think the flip side of this is we do know that some high-risk MDS patients are probably better treated off with AML-like therapies. And so giving us that ability to go to payers and look at treatment algorithms and utilize those therapies for those patients, especially if they're transplant candidates, it gives us that flexibility. So I think from both sides, I do think the argument to hopefully classify patients uniformly and take the best of the both classifications, I think is a good one. In terms of the sort of CHIP, the clonal hematopoiesis of indeterminate potential, and then the CICA space, which is a cytopenias, clonal cytopenias of uncertain significance. There wasn't, I think, a lot of change, except for the fact that I think there's definitely some potential overlap in SF3B1 mutant patients, because as you guys know, if you don't need a certain number of blasts, ring sideroblasts, etc., but you just need that molecular mutation to classify this patient as, MDS, then I think that sort of opens up the question of, when do you use these therapies in these patients if they do have cytopenia, especially anemia? Are you treating patients earlier and earlier in the disease? And so I think there's that gray zone there where I'd be interested in hearing your thoughts on how you approach that. But if it's not clearly called out as MDS pathologically, but an SF3B1 mutation is detected, I think it falls in that gray zone where some people might say, well, this is not MDS yet, but the classification still, classifies it as MDS. So I think that's kind of my viewpoint on the questions you asked.
Sure, yeah, and I would also point out one abstract that I thought was actually quite important, kind of connects to both of what you said, is because I think it's going to increase the number of diagnosed patients, and this was from Dr. Lisa Plyer and the Austrian group that actually showed a very, very nice correlation. We always, like in MDS and chronic myeloid diseases, kind of felt comfortable sending next-gen sequencing from the blood, not only from the bone marrow, but we always had some doubts about things like the variable allele frequency and how accurate is it to capture those. But she showed very nice data that not only you are capturing all the mutations that when you send it from the blood along with the same bone marrow, but also she showed that the variable allele frequency has almost a complete correlation, almost like a 90-degree correlation coefficient, but also even among patients without blast and patients with neutropenia. And I think all of that is very important because I suspect it's going to become more and more part of the standard workup, even of cytopenic patients, even before doing a bone marrow, to send next-gen sequencing. And we are going to see more and more of those patients. Several institutions have even started CHIP clinics where they are seeing even patients just with next-gen sequencing abnormalities without cytopenia. So this is certainly an era that will be very interesting, but it also opens the door of serially monitoring those patients and what happens with the clone over time. So I think it's going to be very exciting. Luckily, we have a bunch of therapeutic abstracts that came out of the meeting also that will be important to discuss. And maybe before I go over the lower risk kind of updates from EHA and ASCO, maybe Andy, can you, for our audience, can you overview the current standard of care in management of lower risk MDS? How would you approach these patients before we go into kind of what came out of ASCO and EHA?
Sure. Yeah, and so maybe I can talk about what I do and then where I think some of the bigger questions are. For us, that is an area where prognostic tools I think have helped. And being able to feel confident that a person really does have a lower risk trajectory, even though our newer scores do tend to upscore people, I think they are more accurate in predicting the natural history of disease. And so when you have someone who's lower risk, I kind of conceptually think of them as someone who's going to live with their disease for a long time. And really my goal is to reduce the impact of their disease, but also of treatment in my clinic, time in my clinic. How can I make their lives as normal as possible, because they're going to have to coexist with this for a while. And for the vast majority of patients, right, they're going to have anemia as their main cytopenia. And that will be the main goal of therapy, will be to first decide when to treat, and then to try to alleviate any symptoms of anemia or the sequelae of chronic transfusions, so iron overload and as such. Now, there are patients who will not have anemia and will fall into lower risk, and they may have neutropenia, they may have thrombocytopenia. There's a lot of variability in how those are managed. For neutropenia, I have many patients where monitoring is fine. I will say that there's some interesting data around IDH1 mutated disease, and this kind of overlaps with CCUS, where patients may respond very nice to IDH inhibitors, and often they do have neutropenia with recurrent infections that prompt treatment. For thrombocytopenia, a lot of it depends on their blast percentage. Some patients may have a concurrent ITP and respond to TPO mimetics and ITP-based therapy. Some patients with pancytopenia, it's important still to recognize that some patients can have long benefit from treatments that are more utilized in aplastic anemia, ATG, eltrombopag, and cyclosporin. But again, for most patients, it's going to be anemia. And so in addressing patients with anemia, typically I have viewed them as people who will live a long time with their anemia, and so I go with a stepwise approach. And historically, that's been to initiate first growth factor. Typically, I use ARNS for convenience of dosing, but there is some variability about what is approved by their insurer. Following that, I usually am looking at luspatercept, particularly in ring sideroblast patients with transfusion dependence. I still sometimes try adding lenalidomide to EPO agents in non-del(5q) patients as a trial, because that can achieve transfusion independence in about a quarter of patients. And eventually, patients may be considered for something like short course hypomethylating agent. Throughout that, there are encouraging clinical trials. So, we're at a larger center, so we do try to explore clinical trials. But in general, you're looking at trying to maximize the value of a therapy for as long as possible while you're giving them treatment. I think that the biggest questions that we are learning about for lower risk disease and have started to prompt, and I'd love to hear what you guys think about these. But one, I historically have not treated people early. I've waited until they need to see me because I view myself as only adding a burden to their lives. And I haven't viewed lower risk therapies as prolonging life, just alleviating symptoms. But there is some recent data that kind of suggests, should we rethink that? And then, the other thing that I've generally not, I've gone stepwise in my approach because I kind of want a patient, if they're going to live years and years with me, to go through, to have every option available. But I've not necessarily thought about optimizing response rate. So for instance, patients who have a borderline high EPO level until recently, I would still potentially trial them on EPO to see if they get a response. Even if there's only a 10 or 20% chance, their toxicity risk from that might be low, and we would know relatively soon. But there is recent data suggesting maybe there are agents that can have higher response rates. And so I think that those are the two areas where ASCO and EHA are starting to challenge my assumptions.
Yeah, thank you so much, Andrew. I think you touched on several important concepts. I think the concepts of sequencing that we have, hopefully several active agents now. You already also talked about the concept of early treatment of patients, and also this is an evolving area. I think the third important area is the potential area of combinations. Now that, again, when you have multiple active agents, the natural questions become always about sequencing and combinations. But I think a fourth area that is important, and we'll also talk about that, also seem to emerge a little bit in EHA, is the discontinuation. This is a concept that we have seen more in CML, like, discontinuation and, what we used to call therapy-free interval, because we cannot cure MDS clearly without transplant, but some very nice data with lenalidomide, and I'll talk a little bit about this. But maybe we can start by kind of covering the two main, I think, biggest abstracts, which were the COMMANDS and the Amer studies. So the COMMANDS, as Dr. Brunner mentioned, luspatercept is already approved in the US and I believe in Europe for the management of ring sideroblast anemia patients from lower risk MDS who are transfusion dependent. That's important to note that this is a label that patients are transfusion dependent who are after ESA failure. So this was based on the Medalist trial, which was a large randomized phase 3 trial, and the approval has been since the year 2022. The two areas where there was some uncertainty with luspatercept, which, to remind the audience, is a transforming growth factor ligand, basically modifier. It traps those ligands and therefore restores late erythropoiesis. The two areas where there was uncertainty is what is the activity of the drug in the frontline setting, because the approval was after ESA failure or patients who are unlikely to respond to ESA. And how does it work in patients who do not have ring sideroblast? Because it seems that patients who have ring sideroblast were more likely to respond based on the phase 2 PACE study. So the COMMANDS trial tried to address this, both of those questions in a very large trial by MDS kind of standards. I believe 350 patients or close to this were enrolled globally, where patients received either luspatercept, which is given subcutaneously every 3 weeks, versus short acting version of erythropoietin. And both patients started with lower doses, but they were escalated. This was, I think, a very well trial. It was stratified by EPO level, transfusion burden, and patients with lower risk disease with low blast count were only allowed to enroll. And the primary endpoint is a kind of a commonly used endpoint in MDS, which is, or lower risk MDS, which is transfusion independence at 12 weeks, but also combined with a median increase in the hemoglobin of 1.5 grams. So it's not only transfusion dependence, but also increase in the hemoglobin by 1.5 gram. And the trial met its primary endpoint, which showed actually transfusion independence in almost 60% of patients who received luspatercept, compared to half of that with ESA, which is 30%. So this is important because this is actually the first time ever we have a drug that beats ESA in the frontline setting of management of anemic lower risk MDS patients. This was durable with luspatercept 2.5 years compared to 1.5 years with ESA. I think where things got a little bit tricky is in the RS negative patients. When you look at the subgroup analysis, luspatercept outperformed ESA and all subgroups, including SF3B1 mutated patients. When you look at and we know that ring sideroblast and SF3B1 tend to significantly overlap, but not all patients overlap. So when you look by SF3B1, luspatercept actually did better in terms of transfusion independence rate. However, when you look by ring sideroblast, it seems for patients who are ring sideroblast negative, which is most patients with lower risk MDS, did not seem to have a huge difference between luspatercept and ESA, although the durability seems still a little bit better with luspatercept. So I think the main open questions after this trial was what is the frontline use of luspatercept in RS negative patients, and of course the questions we discussed about the sequencing and the combination. And then the second trial, which is the Amer study. This is also a phase 3 trial that was also important. Many of the audience don't realize that, but it's actually not common for us in the MDS field to have even one, not to mention two, posted phase 3 trials in the same kind of meeting. So this was a very nice thing for many of us. So patients who after ESA failure, so this is the same setting like the Middle East trial in the ESA failure setting, but this time, regardless whether the patient had ring sideroblast or not, patients were randomized to receive imetelstat, which is a first-in-class competitive inhibitor of telomerase, and this is given intravenously every 4 weeks. And those patients actually were heavily transfusion dependent. They were more heavily transfusion dependent than the trials that were done with luspatercept. The median transfusion burden with those patients was 6 units of blood, almost 1 unit of blood a week, which is quite a bit. And patients were enrolled in 2-to-1 fashion with imetelstat against placebo in a double-blind study. The primary endpoint was again 8-week transfusion independence, and imetelstat basically worked in 40% of the time compared to 15% with placebo. But what was actually more impressive, aside from the transfusion dependence rate, is the durability, which was around 52 weeks, which is quite good by, again, MDS standards, but also the degree of the hemoglobin rise, which was close to 3.5 grams for the imetelstat. So those were patients going from 8 to 11.5, quite a significant rise. And also, we have seen evidence of what we call disease modification, reduction in the variable allele frequency, some cytogenetic responses with clearance of those abnormalities, as well as reduction in the ring sideroblast. So it does suggest that the drug is not only improving anemia, but it might have even deeper impact at the level of the natural history of the disease, which of course remains to be seen. But we are seeing some indications of it. So I think this is like in a nutshell, like the top line summary of both trials. For the side effect profile, we really did not see much with either one beyond what we already knew from the phase 2 and the previous phase 3 studies with the drugs, some fatigue with luspatercept and some muscle aches, and with imetelstat cytopenias, which tend to be reversible and manageable with dose interruption and growth factors and minimal LFT abnormalities. But clearly both drugs can be given for the most part without significant problems. So Uma, what's your take on this data? What are the open questions that remain in your mind once you have seen these data?
Thanks, Amer. So first of all, again, I wanted to echo what you said. I think this is a really exciting time for the MDS field in general, especially the low-risk MDS field, because we see a lot of these patients more than the high risk, I would argue. So I think especially, maybe starting with the COMMAND study, I think the open question is, something that you referred to, the benefit in the RS negative patients. And I think clinically, when I see a patient in my clinic we have the commands data, you summarize it really well. Let's say the patient is RS negative, and let's say they have a really low EPO level and a minimal transfusion burden, maybe one transfusion, a month, or maybe every couple of months. So then I'm going to ask myself, looking at the data that you just summarized, is this an appropriate patient for maybe instead of, going with the frontline luspatercept approach, is sequencing in this patient the more appropriate approach where you start with ESAs because of kind of what you said, you really maximize their exposure to ESAs, and then if you really don't see the kind of hemoglobin increase that you would anticipate, then maybe switch to luspatercept maybe at 8 weeks, maybe even sooner. I don't know the right answer. So I think to me, that patient in our clinic is an open question. I think it's much more clearer if they have RS or SF3B1. I think the commands data is very compelling. And I think the second question is something that Andy referenced is, I think we all know from the MDS world, it's nice to see that hemoglobin rise, but does that actually correspond to the patient feeling better? And I know there are obviously trials looking to see whether early intervention is better. Why should we wait for patients to be more transfusion dependent and then choose one or the other approach and then kind of figure out what's the best thing? Can we modify something in the disease, which has never been a low-risk MDS focus, right? The low-risk MDS focus has always been treat symptoms, maximize, their length of life and hopefully quality of life. But we've never said, let's go out and modify the disease truly to hopefully change, the milieu in the bone marrow. It's always, the focus has been different. So is the luspatercept, data from commands giving us some clues as to, is this possible? And I would go back to sort of the Sintra-Rev study that was not presented at these meetings, but I think is a very important study of early intervention in del(5q) patients who are, doing it earlier than we traditionally would. So I would say those would be my sort of top open questions. With the imelostat data, I think it's a fantastic option for patients, because when they get to the point that the patients were when they entered the IMerge study, there really are very few options. Obviously, I don't know, and Amer, you presented the study, so this is a question for you. Were these patients treated with everything? Did they have, ESAs, luspatercept? Was this failure of everything, and then they kind of went to imelostat, or was this just, you got one thing, you're transfusion dependent, you go to this next? Because then it brings a question of sequencing again. So I'll stop there and eager to hear both your thoughts.
Sorry, I was muted. I think you summarized very well, like the open questions. Maybe to add, I think on the luspatercept front for ring sideroblast negative, I think what we really need to know at this point is what is the activity of ESA after luspatercept, because when you are starting with luspatercept, we are thinking of sequencing our patients, and clearly we don't want to burn any bridges, especially in the RS negative. So I think that's an important question. And the next question in my mind is going to be the combination with ESA, since we know those are potentially synergistic based on retrospective data and different mechanisms of action. So maybe we can get the best benefit for the patient if we combine both drugs, especially if they are both well-tolerated, ESAs and luspatercept. I think for imetelstat it's going to be interesting to kind of answer your question. Those patients were only allowed to have received ESAs, but they could not have received lenalidomide or hypomethylating agents. So that's one open question. We don't know the activity after lenalidomide or hypomethylating agents. So this is something I think will be important to look at. But also after luspatercept, because luspatercept, if it moves to the front line, which potentially this is in front of the idea right now, if it moves to the front line, the question is going to be what's the activity of imetelstat after. So we did have a small number of patients, I think 6 or 7 per arm, who on the Amer study. So I don't think you have a lot of data to go by. Anecdotally, some of those patients did respond. So and think about the mechanisms of action, you probably don't see a reason why they would not respond, but clearly we need more data. But again, I think that kind of reflects to you some of the excitement in the field, almost similar to what has been happening in myeloma field, like multiple agent sequencing, combination, doublets, maybe in the future, triplets, etc. And how do you sequence the drugs? And then I think getting more ambitious and aiming higher with, as both of you alluded to, currently we only don't want to worsen quality of life and minimize transfusions, but can we improve survival? Now we have drugs that potentially could work more on the underlying disease itself. And maybe we can start earlier, as you mentioned. I think Uma mentioned the CentralRev trial, which is lenalidomide before transfusion dependence. There's actually a planned trial with luspatercept called the ELEMENT trial, which also will do the same thing, which is giving the drug in a randomized fashion before transfusion dependence for anemic patients with the disease. So I think this will provide important answers. Before I go to Andrew for his comments, I also wanted to highlight very quickly three other abstracts in the lower risk MDS that I thought were important. One of them is a kind of another class of the same group or another agent of the same group called KER050, which is also a transforming growth factor modifier. This is somewhat similar to luspatercept and sotatercept, but the phase 2 data, which was single arm, was suggesting that it could be better. Of course, we don't know. This is cross-trial comparison. And I think the subsequent trials with this agent will be important. Always good to have multiple agents, kind of options for our patients. The second trial is with the hypomethylating agents, with an oral hypomethylating agent, decitabine, cedazoridine. This is already approved for higher risk MDS. So what is being currently tested is lower doses, along the same idea of, I believe Andrew mentioned, is using lower doses of injectable hypomethylating agents. Here you are using shorter courses, lower doses, and trying to see whether we can give this to patients with lower risk MDS. And the third abstract or concept is the discontinuation, similar to CentralRev, kind of testing the idea of giving lenalidomide before transfusion dependence. The Italian group actually presented nice data about patients who discontinued lenalidomide, not by design, but because of toxicity, or the patient did not want to stay on the drug. And some patients had sustained transfusion independence for years. This was quite impressive because we generally, in MDS, we never do that, right? We try to treat the patient continuously once they start the treatment. So I think this is starting to introduce the idea of this therapy-free remissions. This is, of course, was a retrospective analysis, but I think it's important to study it in a kind of controlled trial setting to see if this can actually work for some of our patients, giving them therapy breaks or building up on this. So Andrew, and I know most of the time has been spent in lower risk MDS, but this is where both meetings have focused on. So maybe in the concluding remarks for both of you, yeah.
There's also a couple of nice questions in the chat about low risk MDS. I don't know, Andrew or Amer, if you guys want to answer them. I think the first one is asking, in both IMerge and COMMANDS trial, majority of patients with low risk MDS are RS positive, 70% in COMMANDS and 60% in IMerge, which is surprising given in practice we see majority of the patients that are RS negative, and they wanted both of you, or all of us, but both of you, to comment on high accrual of RS positive patients in both trials and what impact that had. I don't know, Andrew, if you want to go first.
I mean, I think we can only postulate, although, when I think of patients who don't respond to ESA, who live a long time and only ever have anemia, I think of RS positive patients. I mean, those are the patients that tend to have less clonal evolution toward leukemia. They tend to be the ones who will continue to be red cell transfusion dependent, but not have other problems from their disease, and they'll live long enough to go through multiple lines of therapy. So I think in part it's an artifact of how the trials were designed. So if you have people that you need to go through multiple lines of therapy, that for the IMerge data seems to be my understanding of how that happened. The COMMANDS, I think it's, yeah. Oh, sorry, yeah.
No, go ahead.
For COMMANDS, it's a little less clear because you would think that you would catch a wider net and be more have more representation by RS negative patients in that kind of study. I do wonder if it, because it's approved in RS positive disease later, if there's some element of that, also with EPO levels. But that one I'm not as sure about. I don't know, Amer, if you have any ideas of how that.
No, I fully agree with you. I think patients with ring sideroblast tend to kind of live longer. Their disease is more indolent. They probably tend to stay as lower risk more than other patients. So I think that's a big part of it. But for the commands in particular, I think since we already knew that luspatercept works very well in RS positive patients, I think probably many doctors wanted to enroll on that trial because worst case scenario, you are getting ESA, but you might get luspatercept. So I think that was part of it. And for the second question, before we go to higher risk MDS, they're asking about formal trials looking at ESAs and combination ESAs and luspatercept. So there was retrospective data from Moffitt and other centers about the combinations, which suggested they are synergistic, but of course it was retrospective, not like a trial setting. There is a trial from France called the Compola trial, which adds on luspatercept as a add-on strategy after ESA failure. So it's a randomized trial of luspatercept versus adding luspatercept to ESA, similar to what was done with the cooperative group trial with lenalidomide that Andrew mentioned. And there are ongoing discussions about combinations with ESA with luspatercept. But I think this would be a very interesting area for sure. Uma, we have 20 minutes, which I think is actually probably pretty plenty to kind of summarize high-risk MDS, given that there was not a lot of major updates in those particular meetings, but a lot is happening in the field. So maybe you can take us where we are right now and what are kind of the most important questions and what was presented, and potentially what are the trials that you are kind of looking forward to seeing results from soon.
So thank you, Amer. I think this is really the last few years have been all about MDS, low risk MDS and high risk MDS. And as you mentioned, having large phase 3 studies, readout in MDS is exciting. Having them be positive is even more exciting because we've gone through an era of negative, large, high risk MDS studies. And so now in front of us are actually four large randomized placebo-controlled phase 3 studies that are looking at the high-risk MDS population. These are all high risk by IPSSR. So by IPSSR, these patients are intermediate or high risk. They are allowed to enroll in these studies. The first study that I wanted to mention, just because it's such a well-known agent in the AML space, is the Verona study, which is azacitidine plus venetoclax versus azacitidine plus placebo. This is a fully accrued study. The primary endpoint is overall survival, and that data, and this is an event-based trial, as are most of these phase 3 studies. And I think there's anticipation of this data, maybe even as early as ASH, but hopefully in the next year or so, we'll have the answer from the study to look at whether we can do better than AZA alone. I think the couple of things to mention in this trial are the dose and the duration of ven. Even the dose is 400, with obviously the dose modifications for azoles, the duration is 14 days, unlike the label, which is 28 days in AML. So I think that's an important distinction if this becomes an option in the future. The second study, which I think, again, a lot of us participated in, is the ENHANCE study, which is looking at the anti-CD47 antibody magrolimab, and the same design, randomized placebo-controlled trial, similar endpoints. And obviously in this study, I think we're all very eager to see sort of the impact that magrolimab has on overall survival in high-risk MDS. But, there's been a lot of excitement with magrolimab, specifically in the TP53 mutant population. And even though the study is not designed specifically to look at that, I think, there's definitely interest in seeing if just like we mentioned with the command study and the ring sideroblast and SF3B1, there's always investigator bias and things like that. So I think I'll be interested to see, kind of how that study reads out. Again, could be as early as this year, maybe next year. The third study is the Stimulus MDS2 study, which is again looking at the same population. combining azacitidine with an anti-TIM3 antibody called sabatolimab. All of us here on the call have been very involved in these studies. Amer, you led the phase 2 Stimulus MDS-1 study, which unfortunately did not reach the primary endpoint of progression-free survival, but there was clearly a signal of the longer you stayed on this combination, the better you seem to do. And I think the endpoint for Stimulus MDS2 is overall survival. So again, looking to see, can you truly impact what matters to a lot of our patients, and that's survival. And then the last study that I wanted to mention, which is not as, I guess, talked about, but I think this is the only sort of biomarker-based study in MDS right now. And this is a study looking at azacitidine in combination with a drug called tamibarotene. And for those of you who may not be as familiar with this I call it the super ATRA, because this is almost like a second generation retinoic acid receptor agonist. And the idea is to select patients with high-risk MDS that overexpress RAR alpha on the cells. And they have a blood-based assay for which you screen patients before they enroll in the study. And if they are RAR alpha positive by this assay, then they get randomized to either the placebo arm or the study arm. Obviously, it's a double-blind controlled study. And this study is actually still enrolling and accruing. So the data from this study will not be, I think, available for probably, I would say, a year or even more than that. Since it's still in the accrual phases. So I think, again, historic time, for randomized controlled studies in MDS, looking at the same high-risk population, slightly different mechanisms of action. And I think, Amer, to summarize, if there are one or more approvals in this setting, we're always excited in combination. So how would we utilize this in our high-risk population? But I think the important question is, in my mind, high-risk MDS patients, when they come to my clinic, they fall into we need to take you to transplant quickly, or you're really not going to be able to go to transplant. You're older, you're frailer. I want to maximize your quality of life and, how long you live. And how we decide where these therapies fit, I think, is going to be an important question for us clinicians. So I'll stop there.
Yeah, thank you so much, Uma. This is a fantastic summary. I also like to remind our participants to send us any questions if they have. We are going to have like 5 to 10 minutes at the end to kind of take all the questions. And before I go to Andrew to kind of take his kind of input, to summarize, I think we have 3 fully accrued randomized studies in high-risk MDS. Each one of them had more than 500 patients, magrolimab, sabatolimab, and venetoclax, and all of them are actually expected to report the end of this year or early 2024. So this is going to be kind of a make it or break it year for high-risk MDS. We are hoping at least for 1, if not more, approvals. And then the tamibarotene study, which actually has been recently amended so that it's not only looking at CR, which was the primary endpoint, but it's going to look at overall survival, and it's going to become another 500 patient study. So hoping that one of those 4 would be positive. Of course, we have the IDH inhibitors, which are clearly very active in the relapse refractory setting, probably in the front line, but I think there's a lot of debate about whether to give these drugs before HMA in higher risk MDS, but there's a very clear signal. I don't think we are going to have a phase 3 with these agents because IDH mutations are relatively uncommon. But I want to take your take, Andrew, on one drug that you have worked with quite a bit, which is APR-246. The reason why I mention it, despite having a negative phase 3 study, is because we keep seeing trials kind of coming in high impact journals, like, in the maintenance setting after a transplant. And then I think recently there was a trial in Lancet Hematology combining it with, I believe, azacitidine and venetoclax in frontline AML. So do you think this drug might kind of make a comeback, or is it like kind of gone? And the second question is about, this is something we work together on, like, do you see like kind of triplets kind of on the horizon, similar to what's happening in AML, or do we have to kind of wait for the doublets to kind of pan out? And sorry, I'm gonna stop my video for a second to close the curtain.
Sure. All the easy questions. It is a very interesting space. And it's interesting, to see all these trials go through. Also, just to think how much our understanding of MDS has changed over the accrual period of these trials. And I think APR-246 is a good example. even our understanding of p53 mutated disease is so much more nuanced now. So when we started enrolling patients for the APR study, right, it was anyone with a p53 mutation. And we've since understood that p53 mutations vary quite a bit. The actual mutation varies in its clinical impact on the disease, the presence of biallelic mutations versus not, whether it's in the DNA binding domain. And APR, may work for, say, mutant T53 that doesn't bind to DNA anymore because it has a binding domain mutation. But if you lost the protein completely because of your mutation, it's not clear they would have the same impact. But we went into those trials without understanding all of that, at least, or without applying it clinically. And I mean, it is a little challenging to apply. Even my assays now to try to distinguish biallelic TP53 loss, it's hard to determine. I spend a lot of time with my pathologist trying to say, so how many P53 copies do you think are actually functioning in these cells? So that is, I think, part of the challenge around our studies that we understand from APR 246. We still don't know all the full data from the phase 3 study. It was powered, and its primary endpoint was complete remission rate. And there was a numerically higher complete remission rate in the APR arm, but it was not statistically significant. And it's hard to know in retrospect or without seeing all the data, was that just patient selection? Did we have too many people with biallelic loss or without any expression of p53? Maybe we need mutant protein that is mutant, but we can still target. Hopefully we get that kind of data. And I think that these recent publications illuminate kind of that increased understanding. And, if we can further find a path for it. I'm not in charge of drug development, but there is a great need in p53 mutated disease. And I think that actually is a really good story and good tale to think about for our phase 3 trials, because p53 mutated MDS and AML is increasingly its own beast. It is an entity that we all want compounds to work in. It is a really challenging disease. It is something where transplant has a potential role, but it's not a slam dunk for everybody. Post-transplant maintenance is a much more a consideration in these patients. Relapse and control of disease, remissions are short-lived. And so, we should not exclude them from our trials, but we have to understand that this entity behaves differently. And I think about that a little bit when I look at trial composition. Because if you have a drug that is active in p53, great, that's not going to dilute your power for your trial. But when we look at these big phase 3 studies and we think about, well, if for instance, in the phase 2 sabatolimab study, 30% of patients had a p53 mutation. That's such a high rate of p53 enrollment. And if there's no difference between p53 mutated disease, which we didn't see anything obvious in that subgroup, that's going to reduce the power of your study, right? All of a sudden, your study sample size is 2/3 of what you expected. And so I think that when we see these 3 studies come out in the next year and tamibarotene following, we will be able to learn something from all of them. I hope that we also kind of can learn how we develop and how we classify MDS and how those classifications can impact things. So I would be interested in multiple ways of looking at p53 targeted disease. I think that we did have patients who did better than I expected, and I wish I knew why. And so I think this remains a big challenge for us. As far as triplets, I hope that they will move forward. It's a tough patient population to treat, right? Some patients cannot handle combinations quite the same. The good news, I think, with these actual trials is, if you look at each one of them, all 4 of these, they all have different side effect profiles. And so the possibility of us being able to combine them without getting overlapping toxicity, I think is a real possibility if we get a few agents that show activity. So I'm encouraged that we will be able to develop triplets. Maybe we'll be able to even titrate treatment intensity a little bit based on comorbidities or other factors that are patient specific. But we will have to be thoughtful about how we do it.
I just wanted to add a quick comment to Andrew, your mentioned about TP53 mutated, that the Verona study excludes therapy-related MDS patients, which is not synonymous with TP53 mutated patients, but is definitely, the therapy-related MDS tends to have more high-risk features in general, including TP53 mutations. So I think that's, an attempt, we can argue whether it's the right or wrong thing to do, but it definitely, we know that Ven doesn't really have a lot of activity in TP53 mutated myeloid neoplasms. And so I think that there's definitely a little bit of a difference in Verona compared to, let's say, ENHANCE, or I don't think Stimulus 2 excluded therapy-related MDS patients. I think you're muted, Amer.
Thank you. Yeah, I think all of these are important points, and kind of, if you wanted a bigger example of application bias, here you go. I mean, I think this press release for this phase 3 has been like, what, 3 years ago now, and we still have not seen and even a presentation. So I think there's a lot to be learned from negative data, and I hope we see these data soon. So we have a number of questions. Maybe I can start with you, Oma. So the first question is about CCUS. So which CCUS requires treatment? Cytopenias can be variable, severe, transfusion dependent. Mutations can be concerning. History can be concerning. How important is the morphology of diagnosis of MDS? Maybe I can put it this way: I always joke that CCUS is basically MDS without dysplasia on the bone marrow. Like, does that affect your treatment, whether this is called lower risk MDS or high risk CCUS?
I think sometimes I will say it does. And I think the times that it does affect whether I treat patients or not is really the patient sitting in front of you. Because I think not all CCUS patients are created equal, and just like all CCUS is not equal. I think the CCUS that I think I feel more compelled to treat are obviously, by definition, CCUS patients are cytopenic. And I think those cytopenias are if they're impacting their life and, they're receiving transfusions, they've been admitted for a couple of infection complications, or they've had bleeds. I think that's much more compelling. I think that's rare. Most CCUS patients' cytopenias are not as obvious or symptomatic. I think anemia is common, needing transfusions is more common. But if a CCUS patient has had prior cancer treatment and then has had these myeloid mutations come up, and that those are directly related to their ongoing cytopenias, I think that those are the patients that I really genuinely have a conversation about whether we should treat early or not. And we can talk about what treatment options we can realistically offer. But when you have mutations that we think emerge from prior cancer treatment, whether it be chemotherapy, radiation, and I will tell you now, I have a collection of these patients because I run the clinic of patients who have had curative cancer therapies, whether it be breast cancer, even ovarian cancer, and now they unfortunately have emerging PPM1D, TP53 mutations, and they have cytopenias that we think are directly related to those mutations. And these are relatively, I would say, still young men and women who, want to be proactive and not have another cancer develop to treat with, especially because if they have had PARP inhibitor therapy or even carbotaxol, we know that whatever MDS or AML will emerge is not going to be easy for us to treat. So I think that's, I would say, the patient population that I think we need to definitely be more thoughtful about.
Yeah, so we have a question here, maybe Andrew, about eltrombopag, and there was actually a recent paper in JCO looking at that. So we did not cover that a lot, but I think would be interesting to kind of touch. But how do you approach both eltrombopag and romiplostim in patients with lower risk MDS who are predominantly thrombocytopenic?
Yeah. It's a very heterogeneous group, and so it's really hard to have a rule for these patients. I think you do worry about whether things are evolving in front of you and how much your therapy is impacting that. It's kind of like GCSF, to be honest, giving growth factor in any way. I think that, I avoid it in patients who have increased blasts or borderline increased blasts. And it's not really what I view as a therapy. Say I've got a younger patient, they've got predominant thrombocytopenia, but they've got other cytopenias, and the writing on the wall that, transplant or something is a destination. So this is really kind of more in the palliative setting. I find actually, like in CMML, there can often be a concurrent ITP and they can respond nicely. And that's really, I treat it more like a separate entity in those patients, but with serial monitoring and with bone marrow biopsies. The main area where I think it's kind of got a bigger role, and this is extrapolated as well, is whether or not to use it in the hypoplastic MDS type of setting. Where we have largely borrowed from aplastic anemia. And I think, this is an area where there probably is some overlap between those two entities. But given the aplastic anemia data, considering it in that space. So I don't use it frequently, to be honest. They're generally, by the time somebody is that thrombocytopenic, right, because you have to have platelets really under 20,000, often under 10,000 before people are developing complications. You're usually kind of in between a rock and a hard place, trying to say, are we going to try to do something more definitive for your MDS, or are we going to try to palliate this and accept that there might be some side effects with eltrombopag or romiflostin?
Yeah, thanks, Andrew. Before we go to the last question, which I will direct to Uma, we actually forgot to mention that one of the phase 3s in lower risk MDS that we were waiting to hear about, we kind of heard about the top line results in the journal of press releases. We just have a press release that roxadustat, which was one of the agents that was being studied in lower risk MDS, work on the hypoxia inducible factor pathway, was unfortunately negative. We hope to see the data at one point, but sounds like this drug is not going to move forward. So the last question, Uma, this is a tough one because we deal with it clinically all the time. So this is a high-risk patient by, IPSS-R or IPSS-M by genetic features, but the counts are relatively preserved. So they are not needing transfusions, they have no infections. So would you treat with hypomethylating agents, or do you sit on the patient? My suspicion is, like everything else in MDS, your answer is going to be depends, but I want to hear from you.
I think depends is always the answer, but I think this actually I think Andrew covered this a little bit in the beginning of the talk, and so did you. And I think that's where the IPSS-ML is helpful, and that's when knowing if the patient is a transplant candidate or not is helpful. Because I actually had this scenario very recently in my clinic. Gentleman in his 70s has a U2AF1 and a 20% VAF TP53 mutation, and the counts are actually minimally changed. The patient just had a very thoughtful PCP, got referred to a hematologist early, had a bone marrow biopsy early, blasts are not more than 5%, and he doesn't really have any of really cytopenias that need transfusions, never has had a transfusion. And so we had a lot of discussion, and this patient is a transplant candidate, wants to get curative therapy. And to me, that is, I think, one of the patients that I actually would consider treating, just because I don't have a way to take somebody like that straight to transplant, and our transplanters take time and also prefer patients with some treatment. And it also brings to the question, maybe this is a good way to end the discussion, is what is the role of MRD in MDS? Because if you're going to treat patients like this and you're not relying necessarily on blasts or cytopenias, but you're going off high-risk genetic features like mutations, then do you have a way to follow these mutations if the clones go away or decrease, which I know our transplanters use in AML, and now they're extrapolating that to the MDS field. Then is that something we need to formally look at in high-risk MDS and maybe make decisions based on that?
No, thank you so much. Of course, this is why we always we treat the patient, not the disease. And taking all of these factors into consideration is very important. I actually I have a patient on the opposite spectrum of what you mentioned, a 96-year-old. Imagine 96-year-old with AML a whole year now, with minimal cytopenias, had a bone marrow by outside hematologist, was found to have the AML, was sent to me. She feels very well. She does everything around her home. She still drives. and mild cytopenias. And she refused treatment. I recommended treatment because it's AML 40% plus, but she refused, which probably was a good call on her behalf, because now she's a year out and had no transfusion, no infection. She feels completely fine. And she actually has 2 mutations with DDX41, which again is, I think, kind of starting to explain some of those kind of oddities that we tend to have every now and then. So I think, in addition to what you mentioned, the trajectory of the blood count and, are they dropping down quickly, or what is the molecular type, also can give you a sense of, whether it's reason, especially if transplant is not on the table. In those older patients, I do think it's probably not unreasonable to wait, because the goal tends to be more on the quality of life. But of course, you have to kind of discuss all of this with the patient. So kind of a lot of good questions we went over, but thank you both for coming in and staying over time, and very exciting discussion. Hopefully next time we do this after ASH, we are going to have a bunch of high risk MDS interesting data to discuss, hopefully positive data. Thank you so much, everybody.
Thank you.
Thank you.
Bye.
Bye-bye.